Okay, here we go. Hi, my name is Tali Rosenbaum, and I want to thank you, IUGA, for inviting me to give this talk. My words today really come after decades of working as a researcher and a therapist, first a physical therapist, and then later a couples and individual psychotherapist at the intersection of trauma, pelvic health, and sexuality. And this talk is really not about turning physiotherapists into psychotherapists. It's about a clinical observation. Trauma shows up in the pelvic floor, and our usual models don't really fully prepare us for that. I want to say something explicitly at the start. Nothing I'm describing today is rare or pathological. Many of you have already seen much of this in your clinics, even if you haven't necessarily had the language for it. My goal today is not to change what you do, but to change how you understand what it is that you're seeing. And this is really only going to be a brief overview of trauma-informed care. And if you would like additional training, both in trauma-informed sexual counseling as well as trauma-informed pelvic health physiotherapy, there are several frameworks where I teach that. So please be in contact with me. My email address is on the first slide. Now, we all work within all aspects of the biopsychosocial model, at least in theory, that's how it's supposed to work. But practically, it's really divided such that the functional aspects of pelvic floor dysfunction are assigned to the physiotherapists, while the mental health professionals are meant to treat the psychological aspects of trauma. And that is anxiety, hypervigilance, flashbacks, dissociation, sometimes people-pleasing traits. Now, this isn't a failure of clinicians, it's a structural problem in how care is organized. But the problem is that trauma doesn't respect professional boundaries. Emotional distress emerges during physical treatment. And this is why it's so important for physiotherapists to learn to identify trauma and respond appropriately to trauma responses in the clinic. Now, usually when physiotherapists see this distress happening, they want to help their patients feel safer and more relaxed. And that really does make sense. As Bessel van der Kolk, the author of Our Body Keeps the Score, states, the ability to feel relaxed in one's body requires the emotional experience of safety. The emotional experience, the embodied experience of relaxation and the emotional experience of safety are critical to experiencing attachment, connection, sexuality, as well as being able to be a patient, to be able to engage in physical and medical procedures. And this doesn't only apply to emotional safety, it also applies to muscle tone because it responds to emotions. So when you grow up feeling safe and secure and most of your needs are met, you have the developmental ability to feel safe, to trust. This doesn't mean, though, that you don't have a mechanism for responding to stressful situations. We all have that, and we all need to have that mechanism built into us. And that mechanism is called the stress response. We all have a stress response, also known as the fight, flight, freeze response. When we are in a stressful situation, our sympathetic nervous system responds to arousal by becoming aroused, and it's a normal response to stress. And it's the HPA axis, which I'm sure you're all familiar with. When the acute stress response is activated, chemicals such as cortisol and catecholamines are released to facilitate our survival response. If it's to run away or to fight, when there's no option for that, the autonomic nervous system will shut down in a freeze state. And when the threat, and this is the difference between having PTSD or not, when the threat is perceived as normal, your body returns to normal. The threat is over and you can relax again and you can feel safe again. Now, people in PTSD, that threat response doesn't turn off. It actually generalizes. It's kind of there all the time for when you need it. And it makes it very, very difficult to ever really feel safe. And also people who go on to develop PTSD don't have the easy ability to downregulate, to kind of calm themselves down. And especially if that was a threat that was ongoing in their lives, whether it's ongoing uh, racial discrimination, war, complex child abuse, sexual abuse. And so becoming hypervigilant and being on guard, being ready to react to threat, that was very adaptive, but it keeps the nervous system in high arousal. Now, traumatic experience have a direct impact on how your patients engage in healthcare and how easily they'll connect with you as the therapist. People with PTSD, as I said, are often dysregulated emotionally. They can be chaotic. They may repeatedly miss appointments or cancel appointments at the last minute. Now, medical language can label this as non-compliance. But it's really not about non-compliance. It's about protection. And we have to understand those defenses that have helped people with trauma to survive. They may have a lot of anxiety about certain procedures, and they may not trust you. And it's important not to take that personally, because as nice and kind as you are, even if you're patient and kind and you suggest that they breathe or try to relax, it may take a while before they can get there. As nice as you are, this might be what they're seeing. And this is because for women and men who have experienced any type of trauma, especially sexual trauma, asking them to relax, just relax, can be threatening, because being on guard and sometimes disassociating, checking out, that's what has allowed victims to survive. And so the idea of relinquishing control, just relaxing, can be really terrifying. And it's not a cognitive decision. The amygdala, the threat center of the limbic system, is actively responding to threat. And when it comes to pelvic floor muscles, they are reactive to threat. Now, I want to emphasize something here. This response is reflexive. The pelvic floor is not making a choice. It's responding to perceived threat faster than the cognition. And when I say threat responsive, I mean it's autonomically mediated, not cognitively chosen. So the pelvic floor does react to threat, stress, shame. The pelvic floor is an emotional organ. It's uniquely sensitive. And early research by Van Lunsen, Ellen Lan, Vanderveld, they proposed that high pelvic floor muscle tone reflects part of an overall defensive threat response pattern in the nervous system, rather than like a local muscle pathology. And in lab models, pelvic floor muscles increase activation in response to emotionally threatening stimuli, which aligns with a general defensive response. More recent studies have also looked at the interplay between anxiety and overactive pelvic floor. So when function becomes the primary goal, penetration, tolerance, progress, we can unintentionally override the body's signals. Many patients comply because as abuse survivors, they don't feel entitled to not consent. They learned that their body doesn't belong to them, so they might freeze, they might dissociate, and this can look like compliance or overcompliance, but it's not. As a PT, as a physio, I used to hear things like, just do what you have to do down there, or it doesn't have to feel good, it just has to work. These sentences should stop us in our tracks. And I want to say something even more difficult here. Not all trauma is past or event-based. For many patients, sex has not been experienced as freely chosen, and even the interventions, the dilators, the physio, may not feel that it is coming from a place of agency and autonomy. It might feel obligatory. When sexual activity is framed as something one needs to do, should do, the body learns to comply rather than actually feel safe. So over time, that compliance can become indistinguishable from trauma at a physiological level. So patients who dissociate or have flashbacks in physiotherapy, this can be very dysregulating, not just for the patient, but also for you as physios. And learning how to ground yourself, it's critical. And these are not difficult patients. These are protected patients. Learning the signs of dissociation, the glazed look, the flashbacks, these are important to be able to help yourself navigate working with this clientele. Now, I do want to talk for a moment about sexual functioning. My colleagues and I, and this is because many physios do some amount of sexual counseling. Now, my colleagues and I compared the neurophysiology of sexual desire, arousal, and orgasm to the neurophysiology of PTSD, and we began to understand the incompatibility. Sexual arousal involves responses similar to those involved in the stress response. Our excitatory mechanisms cause heart rate to increase and the blood to flow, but our inhibitory center, like the brakes, let us know that even though our body is in a state of fight or flight, we're not in a state of stress. We're just having sex and we're having fun and everything's going to calm down. We don't have anything to be afraid of, but people with PTSD lack the ability to downregulate. And once they experience sensations and a physiological reality that mirrors stress, they might experience heightened fear. And this is also important for any behavioral interventions that you might want to give. So, for example, for helping with arousal, directed masturbation or giving a vibrator to somebody who has increased arousal, this increased arousal may be overwhelming for them. Also, to somebody who might have been sexually abused or molested as a child and may have had inappropriate genital stimulation done to them, working with a vibrator could possibly create this re-triggering of those sensations. So these are all very important things to keep in mind. Not that you can't do it, but you have to be able to tread very carefully. Trauma-informed pelvic physiotherapy is really about safety, agency, connection, and supporting healing through the work that you're doing. Recognizing that the resistance is not resistance, it's protection, and the non-compliance may be based on survival. This isn't psychotherapy, it's precision, it's attunement, it's connection with your patients. And this connection is so important, as I have nothing to disclose, as I'm going to say in our take-home points. Judith Herman wrote, "Recovery can only take place within the context of relationships. This includes the therapeutic relationship, developing a trusting provider-patient relationship will help your patients to feel more comfortable and to be more empowered." So I want to thank you very much for your attention, and I hope to see you at the Q&A.